Hello. Welcome to the overview of the 2023 AGS Beers Criteria Microlecture 2. This is the second of a series of 3 microlectures designed to give an overview of the 2023 AGS Beers Criteria. My name is Rebecca Brynjulsson. I'm a board-certified geriatric pharmacist and School of Pharmacy faculty member at North Dakota State University in the School of Pharmacy. As we begin this presentation today, I would also like to acknowledge board-certified geriatric pharmacist and NDSU School of Pharmacy faculty member Mark Dewey, who also contributed content to this presentation. At the completion of this series of 3 microlectures, the participant will be able to identify basic principles of medication use in older adults, summarize the changes in the 2023 AGS Beers Criteria, analyze patient cases to identify potentially inappropriate medications and understand their role in common prescribing cascades. Identify practical solutions to reduce potentially inappropriate medication use and polypharmacy for providers. As a refresher from Microlecture 1, the 2023 AGS Beers Criteria are organized into 5 tables, with the following titles. 1. Medications considered as potentially inappropriate, Table 2. 2. Medications potentially inappropriate in patients with certain diseases or syndromes, Table 3. 3. Medications to be used with caution, Table 4. 4. Potentially inappropriate drug-drug interactions, Table 5. 5. Medications whose dosages should be adjusted based on renal function, Table 6. The quality of evidence ranges from low to high, and the strength of recommendation ranges from weak to strong. With that, let's continue to highlight some of the new and/or updated recommendations in the 2023 AGS Beers Criteria, considering items in Table 8, quote, medications criteria removed since 2019, AGS Beers Criteria, end quote, Table 9, quote, medications criteria added since 2019, AGS Beers Criteria, end quote, and Table 10, quote, medications criteria modified since the 2019 AGS Beers Criteria, end quote. Note the recommendations reviewed in this series of microlectures will not be comprehensive, and participants are encouraged to review the 2023 AGS Beers Criteria to assure that they understand the recommendations surrounding medications that may be more commonly used in their practices. It is also important to note that the medications discussed as highlighted, new and/or updated recommendations may be changes to one table only, and the medications may have other recommendations that appear in other tables that did not require updating with this new publication. Next, we'll move on to additions to Table 5, clinically important drug-drug interactions. In this category, we see first warfarin and selective serotonin reuptake inhibitors, SSRIs, interacting to cause an increased risk of bleeding. This is a strong recommendation with moderate quality evidence. Interestingly, additional work has been published since the 2023 AGS Beers Criteria. Rahman and colleagues published an article in the Journal of the American Medical Association Network Open in March 2024 titled Concomitant Use of Selective Serotonin Reuptake Inhibitors with Oral Anticoagulants and Risk of Major Bleeding. They looked at atrial fibrillation patients using SSRIs and oral anticoagulants, both direct oral anticoagulants and vitamin K antagonists, compared to patients using only oral anticoagulants using a nested case control study. They found that patients with SSRI and oral anticoagulant use had an increased risk of major bleeding, especially in the first few months of concomitant use, and risk continued for up to 6 months. Quote, the overall risk remained consistent, regardless of age, sex, potency of SSRIs, history of major bleeding, or chronic kidney disease, as well as type of OAC, end quote. Further, quote, our findings also suggested that the concomitant use of SSRIs with both direct oral anticoagulants and vitamin K antagonists was associated with an increased risk of major bleeding, with a possible lower risk with direct oral anticoagulants, although 95% confidence intervals overlapped, end quote. The next addition to this table is lithium, interacting with angiotensin converting enzyme inhibitors and angiotensin receptor neprilysin inhibitors, resulting in increased lithium toxicity risk. This is a strong recommendation with moderate quality evidence. The final addition to Table 5 clinically important drug-drug interactions is the addition of skeletal muscle relaxants to the list of CNS active medications. The recommendation here is to avoid using skeletal muscle relaxants with 2 or more additional CNS active medications to minimize the risk of falls and/or fracture. This is a strong recommendation with high-quality evidence. Next, we'll move on to Table 6, avoid or reduce dose with reduced kidney function. On this table, baclofen has been added as a medication to avoid with an eGFR less than 60 milliliters per minute due to, quote, increased risk of encephalopathy requiring hospitalization in older adults, end quote. This is a strong recommendation with moderate quality evidence. Now we're going to shift from additions to the Beers criteria to modifications to placement of items in the 2023 Beers criteria based upon new and/or changing evidence. The screen before you shows medications that have moved from Table 4, use with caution, to Table 2, potentially inappropriate medications. First, we'll start with aspirin for primary prevention of cardiovascular disease. It is important to note that this recommendation only applies to individuals using aspirin for primary prevention of cardiovascular disease. The evidence has continued to accumulate over the years, leading to this Beers criteria change. The risk of starting aspirin in older individual for primary prevention of cardiovascular disease outweighs the benefit. We should avoid starting older individuals on aspirin for this indication and consider deprescribing aspirin when used for this indication. Patient education is important as this medication is available over the counter, and the recommendation for use may be confusing for patients as they may have friends and family who use this medication for secondary prevention of cardiovascular disease. This is a strong recommendation with high-quality evidence. The next change is rivaroxaban for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism, VTEL. As we continue to use direct oral anticoagulants in patient care and continue to conduct clinical trials, we're learning that not all direct oral anticoagulants have the same level of bleeding risk. The rationale for this change is as follows, quote, at doses used for long-term treatment of VTE or non-valvular atrial fibrillation, rivaroxaban appears to have a higher risk of major bleeding and GI bleeding in older adults than other direct oral anticoagulants, particularly apixaban, end quote. Because of this, it is recommended to avoid rivaroxaban in favor of other direct oral anticoagulants. The next change to Table 2, potentially inappropriate medications, is expanding the recommendation from just the long-acting sulfonylureas to all sulfonylureas given data to support the change. The rationale for this is multifactorial, and the overall recommendation to avoid sulfonylureas is strong. The increased risk of hypoglycemia is well established with high quality of evidence. The increased risk of cardiovascular events and all-cause mortality with use has a moderate quality of evidence, and the increased risk of ischemic stroke and cardiovascular death has a low quality of evidence. The next change for Table 2, potentially inappropriate medications, is adding additional adverse outcomes in the rationale statement and level of evidence for proton pump inhibitors, given supporting data. As you can see highlighted in yellow, pneumonia and gastrointestinal malignancies have also been identified as potential risks to using proton pump inhibitors in older individuals. These new additions have a moderate quality of evidence. The last Beers criteria we're going to talk about today is in Table 4. Medications to be used with caution in older individuals is dabigatran for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism or VTE. The following rationale has been provided, quote, increased risk of GI bleeding compared with warfarin, based on head-to-head clinical trials, and of GI bleeding and major bleeding compared with apixaban, based on observational studies and meta-analyses, in older adults when used for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism, end quote. The recommendation, then, is to use dabigatran cautiously. This is a strong recommendation with high-quality evidence. Overall, there have been several changes recommended in the 2023 Beers criteria that impact vitamin K antagonist recommendations and direct oral anticoagulant recommendations for the treatment of VTE and non-valvular atrial fibrillation. Box 1 in the Beers criteria attempts to help the reader to synthesize information related to the anticoagulation recommendations found throughout all tables. Both warfarin and rivaroxaban have a avoid use recommendation, Table 2, and dabigatran has a use cautiously recommendation. It is also important to note that while we have not discussed Table 6, medications needing adjustment in renal function in detail, direct oral anticoagulants do have differing dose recommendations at different levels of renal function. Let's practice these recommendations with a case example. A 68-year-old female with non-valvular atrial fibrillation is being seen in clinic today for an annual wellness exam. Upon review of her medications, you see she is taking dabigatran 150 milligrams by mouth twice daily. Her creatinine clearance is 65 ml/min. Based upon the updated 2023 AGS Beers criteria, what recommendation would be the safest for the patient? A. Continue dabigatran 150 milligrams by mouth twice daily. B. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin warfarin 2.5 milligrams by mouth daily. C. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin apixaban 5 milligrams by mouth twice daily. D. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin rivaroxaban 20 milligrams by mouth once daily. The presentation will pause for a moment to let you consider the choices. The correct response is letter C. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin apixaban 5 milligrams by mouth twice daily for the safest direct oral anticoagulant recommendation. If you recall, both warfarin and rivaroxaban are on the avoid list. Dabigatran should be used with caution. Now that we've spent time talking about all the medications to avoid and/or to use cautiously, it's good to address deprescribing. The Beers criteria included a section on deprescribing in this most recent update, acknowledging that it's important and has many challenges associated with it. First, let's define deprescribing. It's more than just telling a patient to stop taking a medication. Krishnaswamy and colleagues provide the following for us to consider. Quote, a comprehensive definition of deprescribing should include 1. An organized process of medication removal or dose reduction. 2. Oversight of the deprescribing process by an appropriate member of the healthcare team. 3. A goal of improving one or more specific outcomes. 4. Consideration of an individual's overall physiological status, stage of life, and goals of care, end quote. There are also numerous situations in which it should be considered, including adverse drug reactions, polypharmacy, prescribing cascades, end-of-life palliative care, and changes in risk versus benefit since medication originally prescribed. We'll discuss prescribing cascades in more detail in the next microlecture. There are instruments available to help guide deprescribing decisions. Examples of implicit instruments which help to guide a practitioner's clinical reasoning include SMOG, screening medications in the older drug user, MAI, Medication Appropriateness Index, ARMOR, Assess, Review, Minimize, Optimize, Reassess, Timer, tool to improve medications in the elderly via review. ACOV3, Assessing Care of Vulnerable Elders 3, GPGPA, Good Palliative Geriatric Practice Algorithm, and AOU, Assessment of Underutilization. Explicit instruments that provide guidance on specific medications are also available and include the AGS Beers criteria, STOP, screening tool of older persons potentially inappropriate prescriptions criteria, and STOP P frail, STOP in frail adults with limited life expectancy. There are also several online resources that include links to many more available resources for healthcare providers. On the screen, I've provided a link to the National Institute on Aging U.S. Deprescribing Research Network, resources for clinicians, as well as the Canadian Deprescribing Network. The Canadian group has done a lot of work on deprescribing and has links to deprescribing.org, deprescribing practice guidelines and algorithms for a variety of medications including benzodiazepines, proton pump inhibitors, antihyperglycemics, antipsychotics, and cholinesterase inhibitors, and memantine. This concludes the second AGS Beers criteria microlecture. This slide provides the references for the presentation. Please continue to the third and final AGS Beers criteria microlecture. Thank you.